All right, good afternoon, everybody. Thanks for joining today. Today's webinar is about, as the title suggests, navigating PBM audits. Keep in mind that we will be having another webinar in November, so please be on the lookout. And given that we only have 30 minutes today, let's please utilize the Q&A feature that should be on the bottom of your screen, and then we'll try to answer as many questions as we can at the end of the webinar. Disclaimer, the legal stuff, the webinar is only educational purposes and, shall not be construed as a legal advice or legal opinion. Sorry, I had to say this. I have to say that. About our firm, our firm, Frier Levitt, is a, we're a national firm. We're based out of New York and New Jersey, but we have clients throughout the country from Hawaii to New York and to down south, Florida and Texas. We focus exclusively on healthcare and life sciences. We represent a variety of stakeholders, including pharmacy and pharmacists on a variety of legal issues, namely PBM audits and network participation, board of pharmacy matters, or like government investigations involving prescription drug claims. We do not represent, absolutely have zero conflict of interest to go against PBMs, especially the big three. CVS, Caremark, OptumRx, and Express Scripts, and we do sue them on a regular basis. My name is Dae Lee. I'm one of the partners at our firm, Frier Levitt. I'm in the PBM/pharmacy department. I also co-chair the firm's plan sponsor practice group. I was a pharmacist before, and on a daily basis, I help and assist independent pharmacies like you guys, in your endeavor against PBM. So whether it be PBM audits, network suspension, or network termination. When I wear my plan sponsor co-chair hat, I represent employers, manufacturers, again, against their dealings with PBMs. And today I'll be presenting with my colleague, Harini.
Hi, everyone. My name is Harini Bupati. As Dae mentioned, I also work alongside him on a number of PBM-related issues. We represent a wide range of providers against PBMs on issues such as network access, audits, terminations, fraud, waste, and abuse investigations, and our firm handles essentially the A to Z on pharmacy-related issues, including transactions, board of pharmacy investigations, and sort of the whole gambit. So we can get started with the different types of audits that you might expect for a PBM. You have starting with on-site and virtual audits. The word virtual is sort of new, I'd say, just because of COVID-19, that we've seen a lot more virtual audits. On-site audits and virtual audits could happen at the time of credentialing into a network or once you're in the network, and you can expect that a PBM is going to look at essentially everything related to the pharmacy, starting with something as simple as whether or not the pharmacy is clean, whether it's organized, whether its inventory is separated. And that's a key thing as well, to make sure its inventory is separated. It's important that the pharmacy not only adhere to PBM terms, but of course, treat this as though it's a board of pharmacy inspection to make sure that their inventory is otherwise organized and separated and locked and secured as required under your state's board of pharmacy rules. Another thing is to make sure that the pharmacy's employees have appropriate access over to the pharmacy. For example, we've seen instances in where a pharmacy's owner's spouse might be the bookkeeper of the pharmacy, might have unrestricted access to the pharmacy during non-operable hours of the pharmacy, and PBMs have taken that to be a concern with. Boards of pharmacies have had a concern with that issue, and so it's important to make sure that only employees, and those two disclosed employees over to a PBM, have access to the pharmacy at all times. Another basic thing, but it's important, is to make sure that the pharmacy is open during the hours of operation. That's being reported to the Board of Pharmacy, to your NCPDP, as well as to all your PBMs. For example, again, at the time of credentialing, if an on-site auditor comes to the pharmacy and sees that your pharmacy is not in operation or open for that time of the on-site unannounced visit, that could be a reason for you to be denied credentialing and then have to wait a whole 6 months to a year before you can apply for application. This also applies to something as simple as federal holidays. Perhaps the pharmacy didn't consider that it'd be closed during Labor Day or Columbus Day, or any other federal holiday. Those are things to also consider and to make sure you're reporting in the event that a PBM comes for an on-site audit. I've seen an instance in which PBMs come to a pharmacy to audit during President's Day. Pharmacy was closed, pharmacy wasn't able to be audited, and so the pharmacy had to wait a year before it was able to apply for admission. The next things to make sure and that the pharmacy is keeping mind of is whether the pharmacy has a proper system and policy for the destruction of PHI. That's very important to make sure that that the records or any information is being properly disposed, shredded, and whatever the policy in place is being appropriately followed. Another thing that we see at the time of an on-site audit is to make sure that the pharmacy's appliances are otherwise being appropriately used for pharmacy use. So for example, if the pharmacy has a refrigerator, is it being appropriately used for just pharmacy use? Are folks putting their meals in? Are they being distinguished between the pharmacy use versus personal employee use? If so, if you do have a refrigerator, do you have a refrigerator log? Again, some of these things might not be Board of Pharmacy requirements, but they might be PBM specific requirements. For example, OptumRx requires that you have a refrigerator log. And we have seen PBMs, including OptumRx, deny pharmacies for that exact reason. So again, things to keep in mind. Another important thing during on-site audits is to make sure that you're making sure that you don't have expired, recall, damaged, altered drugs, or even close to expiration drugs, again, all in accordance with the Board of Pharmacy rules on your pharmacy shelves at the time of a PBM audit. Similarly, you'd also want to make sure that you have a proper system and policy in place for how you handle any sort of dangerous controlled substances, another thing that PBMs will be looking at. Also, when you are expecting an on-site audit, you can also anticipate that the PBM auditor is going to look at, again, every aspect of the pharmacy business, aside from, of course, prescription records. So for example, if you've disclosed that you don't mail prescriptions, but the PBM auditor comes into the pharmacy and they see a stack or a pile of medications that are intended to be shipped out, that might really question whether or not the pharmacy was honest in its credentialing application and also about its participation in the network. So another type of audit, aside from on-site and virtual audits, this is more of a desktop audit, inventory reconciliation audits. During an inventory reconciliation audit, you could expect that the PBM is going to ask for your purchase data directly from your wholesalers to be compared against the amounts that you dispensed during a particular time period. So for example, for the calendar year of 2022, a PBM might ask you to get all your wholesalers that you've ever purchased medications from for their PBM's patients and send that information directly to the auditor. In addition, they already have your dispensing data, so they'll compare that purchase information against their dispensing data. It's also not uncommon during the time of credentialing, or depending on the type of payer, that a payer might ask for all your dispensing data across all your payers. So of course that would be redacted information that you'd be providing, but it's to make sure across all your payers that you have sufficient inventory. And we'll get into it later about what it means to maintain sufficient inventory, but it is important that you understand what a reconciliation audit might otherwise entail. Another thing to consider is, aside from purchases from wholesalers, if you've made purchases from any other pharmacies or any other entities or marketplaces, that you're also providing that relevant purchase information over to them for consideration as well. Again, when you're providing this information and you identify any sort of concerns or discrepancies, such as misbilled NTCs or any other issues, it's important to be proactive in raising them and addressing them.
Another thing that PBMs look out for is the compliance with their provider agreement and provider manual. That the PBMs, including especially the big three, have been amending their provider manuals on an annual basis, and they also send out these communications on a very regular basis, whether it be quarterly or even weekly or so. And you really need to be on the lookout. Like, for example, Caremark keeps adding drugs to their aberrant product list. and they recently updated their arbitration provision, changed the venue from AAA, American Arbitration Association, to JAMS, which is a significant move by Caremark. And there's been also communication regarding COVID-19 claims that were, waivers that they issued during COVID-19. And because the PHE has ended earlier in May, some of them expressly retracted those waivers. And nowadays, another thing that they really look out for is the pharmacy's policy and procedure. I know that a lot of pharmacies. So moving along, the records keeping is a key for pharmacies because PBMs, they only accept certain documents when pharmacies dispute audit findings. For copays, Harini will go in detail later on, but for copays, they usually ask for receipts, bank statement, receipts with the last 4 digits of credit cards. If it's cash, cash payments, then they will ask for bank deposit slips, which is bizarre. And in some extreme cases, they've asked for credit card merchant reports, and also they always ask patient attestations. And the other thing that they always look out for is the refill requested by the patient, because some pharmacies and a good number of pharmacies have implemented auto refill policy and is, or feature within their pharmacy software. So pharmacies just build those claims through auto refill feature, and without speaking with the patient, confirming whether that the patient actually do want the refill or not to be filled at your pharmacy. And they look out for those records, patient verification or patient confirmation. And these are easy target by PBMs, and they're going to request the pharmacy they're going to flag those discrepancies in audit findings. And you, unfortunately, have been tasked with disputing the audit findings, and you have to collect the documents. Without the proper documents, it's very challenging to dispute the audit findings and the discrepancies. And, PBMs, they're going to recoup money, and then they may impose additional sanctions, whether it be network suspension or termination. So in terms of prescription and prescription verification, this is what we've seen in the recent past as a hot button item, even on like eScripts, right? eScript, you receive this prescription directly from the prescriber's office. Even those are being scrutinized, and then PBMs try to attack those claims and try to recoup money on those. So you have to verify the prescriber patient relationship. You have to verify the pharmacy patient relationship, and you have to make sure that these prescriptions are being sent directly from the prescriber's office. Okay, and also, are these medically necessary? For Medicare Part D claims, are these written for conditions that are mentioned in the Medicare Part D compendia? All those need to be scrutinized and verified to avoid any unnecessary attention from the PBMs.
I just want to mention one thing, Day, because you mentioned the auto refill system, and it's not to suggest, as Day mentioned, that you can't have an auto refill process in place. It's just to make sure that you're otherwise implementing it as making sure you're having the authorization from patients prior to the point of dispensing, and also maintaining documentation information as required by the PBMs too. Yeah.
Exactly.
Another important area of concern for a lot of PBMs is in relation to copay collection. It's a standard request that we see PBMs ask for when it comes to on-site audits or desktop audits of pharmacies. So it's expected that when you do provide prescription information at the time of an audit, that you'll also be expected to provide copay information for a lot of the prescriptions, if not all of the prescriptions where there was a copay. So to that end, it's really important to make sure that pharmacies are collecting copays from patients and maintaining appropriate documentation. Like Day mentioned, there's enhanced documents that we're seeing a lot of PBMs now require. So for credit card receipts, that would otherwise have been completely fine, PBMs are taking it a step further and suggesting that you need to provide them with the merchant report, meaning you have to go back to your processor and say, hey, can I have, proof that this claim was this credit card transaction ended up in a payment to me, the pharmacy. So it's important that you're also maintaining that information or have access to it. Keep in mind that a lot of the times these merchants might not have access to these reports for 2 years prior, and sometimes an audit might be significantly prior, so it's important for you to maintain that information independently. Same thing with cash receipts. While your POS register receipt might have otherwise been completely fine previously, a lot of PBMs now want to see that you're also showing a corresponding cash deposit slips. In fact, some PBMs have gone so far as to suggest that you need to be able to link a cash deposit to an actual copay that was paid at the pharmacy, which means that pharmacies might need to maintain internal record keeping that they say, okay, patient paid X copay, I went and I deposited X copay of X dollar amount into the bank on so-and-so date, and that you're keeping an internal record. It's definitely extreme requirement, but it's something that we're seeing PBMs also expect of pharmacies. And to that extent, if in an instance where the pharmacy isn't collecting copay, is the patient on a patient payment plan? Are they exhausting efforts to collect? There should all be documented efforts to collect. There should be an internal, it's very important, and we can't emphasize this enough. It's important for a pharmacy to maintain an appropriate and a detailed, extensive copay collection policy. Either you're collecting at the time that you're dispensing the medication, or in an alternate situation that you're having a policy that shows exactly what to do in that instance. To that extent, if you have any sort of manufacturer coupons or patient assistance programs, to make sure that you're also showing that you at the pharmacy are still receiving payment for any secondary claims that are being submitted, in addition to having to submit any sort of claim submissions or screenshots over to the PBM. And to that extent, if in the instance a patient suggests that they can't afford their copay, the pharmacy would want to make sure they have a written financial hardship policy. Again, this is not just something that you need to maintain from a regulatory perspective, but there's enhanced and additional requirements that PBMs also place in terms of copay collection, and also the parameters of what a financial hardship policy might even look like. Notifications to patients, how long you're supposed to be reviewing the patient for financial hardship for, and how often you're supposed to be reviewing them, what types of documentation, etc. Those are all important aspects of copay collection that the pharmacy should certainly make sure that they're considering and documenting into a written policy that's actually being adhered to.
One thing that I wanted to add is that Caremark requires pharmacies to not delegate copay collection function to a third party. That is a provider manual violation, and Caremark will delve into it. Caremark has a lot of qualms about it, and it could be, and it has been, basis of network termination. So I really want you guys to know the provider manual terms. I mean, of course, it's like 100-something pages. You can't memorize everything, but certain things like this, copay collection delegations must be in-house, at least for Caremark.
Yeah, and sometimes you'll know what the areas of focus are based on those reminders or those notifications and alerts you get from PBMs, like Dave mentioned at the beginning of this, is that you can see what their areas of focus are. Sometimes it might just be reminder, you're supposed to be doing X, Y, and Z as a provider in our network. So those are the communications you certainly want to keep an eye out for. And as we mentioned before, we have PBMs also conduct invoice reconciliation audits. Again, it's something where they're comparing the amounts purchased during an audit period and comparing it against the amounts dispensed. It's important that pharmacies consider performing their own internal invoice reconciliation on a regular basis. It doesn't have to be quarterly. It could be monthly. It could be even annually, something to show that you're actually comparing and you're actually having some sort of internal record keeping of your inventory. To that extent, pharmacies should make sure that they are purchasing from otherwise licensed wholesalers or VAUDT accredited wholesalers, NABP VAUDT accredited wholesalers, for example, for any medications that are being dispensed to OptumRx patients, or from authorized distributors of record in the event of diabetic testing supplies. So it's important to make sure that you're purchasing from otherwise acceptable wholesalers, depending on the PBM. Of course, each PBM has their own requirement, so that's something to consider. I'd say catch-all is NABP ROD accredited, and then also authorized distributors for diabetic testing supplies. Another thing to keep in mind is to making sure that you're at the time of claim submission, the pharmacy is accurately submitting a claim for the medication that's actually being dispensed by an NDC level. So that would eliminate any sort of issues about a pharmacy dispensing a generic but billing a brand, for example, which is a significant concern for PBMs, or even something as simple as a different NDC for a generic versus generic drug, which is still a point of an audit concern and potential recovery for a lot of PBMs during the time of an audit. To that extent, some PBMs will also have requirements of how soon you have to dispense a drug once the claim is being billed. So for example, 14 days. If the medication is not picked up, if it's the patient hasn't received it for some reason, the pharmacy should be reversing the claim and returning the medication to stock. Again, when it comes to policies and procedures, this is an important policy and procedure to make sure that the pharmacy has in place, and that all of the pharmacy's personnel are also trained, especially those who have purchasing power. There's many instances where we'll hear a pharmacist purchase a medication because I got a call from a third-party wholesaler that might have offered a discount, wasn't properly documented for the purchase. Might be an issue during the time of an audit because they're not able to confirm the licensure of the wholesaler or even any documentation relating to the purchase. So those are all things to consider when you're maintaining your inventory.
I also want to add that like certain diabetic test supply manufacturers have been taking legal action against pharmacies who purchase their products through unauthorized distributors, whether it be actual lawsuit or demand for payment or demand for additional information regarding the products that they purchased.
In addition to that, Dave, that reminds me, another good point is that it's in addition to manufacturers of diabetic testing supplies, you'll also have manufacturers for whose coupons are being applied towards products. And if they don't believe that you purchase enough medications from from themselves, the manufacturer, they will also send you a recovery letter because you've processed coupons for their products, but they don't believe you to have purchased sufficient amounts of their medication.
Prior authorization is another hot area. Pharmacies, I don't blame them. Pharmacies want to help patients who've been waiting for their prior authorization to be approved. And in fact, a lot of time is just sitting at the prescriber's office. But keep in mind that PBMs, they do record calls and they do contact the prescriber's office and try to confirm whether the prescriber's office actually filled out the PA forms and then submitted the authorizations directly to the PBMs or the insurance companies. Caremark, I think, yes, Caremark actually updated their provider manual and issued a, I guess, provider education. That's what they call it, indicating that pharmacies or participating providers shall not have any involvement whatsoever in the prior authorization process, other than initiating the prior authorization process. So it is important that you train your staff properly to be in compliance with the provider manuals, and you need to make sure you have policies and procedures and regarding the prior authorization. And you need to train your staff, and your staff shouldn't have login credentials of the prescriber's Cover My Meds or whatever it be. But you need to be really careful about the prior authorization process. And we've assisted pharmacies craft the policies and procedures and enter into MOU with prescribers to set the clear boundaries of the pharmacist's involvement and the boundaries of the prescriber when it comes to prior authorization. And in fact, it actually expedite the prior authorization process, and so that the prescriptions can be dispensed to the patients in a timely manner.
And just really quickly, and to the extent that you have any level of involvement in a prior authorization process, it's also noted that when making any communication over to a PBM or plan, you can expect that most of your conversations are being recorded. In fact, during the time of a PBM audit, it's not uncommon for them to reference recorded conversations. So for example, a pharmacy calling on behalf of a prescriber to check in on the PA status. So it's very important that if you, a pharmacy, are calling in for the status of a prior auth, that you're clearly representing who you are calling from and what your position is at the pharmacy, or, again, not misrepresenting that you are in any sense the provider.
Mhm. All right. Another easy target is signature logs. You need to make sure that you have signature logs signed by the patient or signed by the patient authorized representative. If you deliver the prescription, then you need to have a proof of delivery. But sometimes, pharmacies and the delivery driver just leaves the prescription medication, on the doorstep of the patient if the patient is not there. And a year or 2 years later, and when the claim is being audited, the pharmacy has no proof, and patient is unlikely that the patient will remember receiving such medication. Then it becomes a patient denial or other discrepancy code. So you need to make sure that you have robust policy and procedures about signature logs as well as a proof of delivery. And for COVID-19 claims that were filled during COVID-19 and thereafter, these claims, shortly thereafter, these claims are being audited. And even though PBMs say, oh, the PBMs allow the pharmacist to write COVID-19, these claims are still being audited and are being under, scrutinized by the PBM. So you need to make sure that you have some sort of proof to refute those findings. Otherwise, it's an easy target because they're going to collect the entire reimbursement amount that they already paid. They already approved on a claim and they already paid, and which is challenging for pharmacies because they're already dealing with low reimbursement rates pushed out by PBMs. I mean, look, our firm has been assisting pharmacies over the past 2 decades, and the landscape is changing. PBMs are being scrutinized by different legislators, a level of legislators, whether it be the federal level or the state level. And states are more, they're more, there are more bills or laws at a state level that regulate PBMs. So, but that gives more motivation for PBMs to secure their bottom line, right? And audits have been used as a source of revenue for PBMs. And we've been assisting pharmacies, we've been fighting. There are certain tools that are available to the pharmacies. So, and we need to, and we have been, and we need to make sure the pharmacies, do not lose any more money on audit findings. All right, I think that's the end of our webinar. Like I said before, we are going to have another webinar in November, so please be on the lookout. Harini and I will be at the NCPA this coming weekend, spilling into Monday and Tuesday. So if you are there, please feel free to swing by our booth. I think our booth number is 1011. And we'll be there to answer any questions that you may have. And if you're not going to be there, feel free to shoot us an email, and then we'll properly answer your questions or even set up a follow-up call.
Thanks, everyone. We realized that today's time was short, but hopefully when we meet again in November, we'll be able to get into more depths and also talk about, like Day mentioned, some of the legal tools that you have available to yourself to be able to challenge some of these issues when it comes to PBM audits. Thanks so much.
All right. Thanks, everyone. Bye.